Thank you very much for coming to now. I can also whisper. Thank you very much for your invitation, for the opportunity to present here. My name is Antonio. I'm half Italian, but the company I work with is DIERS. It's a German company. And today I will just bring you a few aspects about concepts in biomechanical assessment, starting from static posture up to functional and biomechanical dynamic measurements. And the main question and the topic of the seminar was why is static essential, but why is dynamic much more better? Presentation. Okay, so DIERS is a family-owned business, very small company. We have 30 people, and the intention was to create a company basically on the invention and the technology to avoid X-ray in radiation, like in scoliosis. Having a device that is non-invasive, where you do not have to repeat a lot of radiations in a scoliosis follow-up. So along these years, we have an experience of over 25 years. Next year, we compute 30 years. We are, let's say, spread it in more than 50 countries. We have over 2,000 systems installed, like customers, clinics, universities, believing and also cooperating with us and also using the system every day. Just some technical things. As we also have subsidiaries, so we always try to have a customer service relation also with cooperation partners, universities, especially when you have those empiric works in gaining the data, exporting the data from our software, which you will see later on. It's a mess. So you here as a university, you have the chance to work in each kind of field that is related to your daily work later on in your professions or also in your scientific studies. The presentation is in Thailandese right now. It will change to English because I'm not still perfect in this language. Sorry for that. But what I want to stress out is that basically coming and becoming or getting this system will always be, let's say, a good chance to have a diagnostic tool which is objective and not subjective, because everyone who is relating to 3D scanning or plumb line easily, it's, let's say, you can do that, but this is 100 years of old technology. Yeah? So basically what we are having here is basically a technology which is further developed. To the partners which we have, so all clinical data that you see and will see during this day, let's say have a background which is from renowned universities worldwide, from Charité Sapienza in Rome, University of Tübingen, Hamburg, and many, many, many more. Your logo is missing here. So okay. Yeah, here just the world map. This is where we are. So Thailand is right now. This is our scope, and we have a lot of products. So the core product which we have is called DIERS formetric. And what is the formetric? As I mentioned in the beginning, the main approach was to avoid X-ray in scoliosis, having a system that is non-invasive. So to get at least the picture that is representing the spine in a follow-up, especially because we know that once you have a brace, once you do X-ray, let's say 4 or 5 times a year, the cancer rate in female is highly elevated. So the main task was to have a system that is reliable and repeatable, so that you have an X-ray and then a follow-up later on, years after, yeah, without having that. And the main difference is that if you take an X-ray, so everyone knows how is the X-ray done. Like you're standing like this, so you change your hyphotic and lordotic angle, and if you do an X-ray, sometimes you stand like this, and you stop breathing. You don't have to move. So 1996, let's say in the 80s and 90s, this was also one big topic to overcome. How is the system working? We do have a projector, that's a formetric. We have a projector that is emitting stripes on the back of the patient. We have a camera that is calibrated, and we're looking onto the back. It's like a topographer, okay? It's a spine and surface topography. And the question then is, the data is capturing that. We have a PC integrated in that system, and then we are calculating our algorithm. And also here there is a clinical study and also a validation. There's a correlation model that gives us the chance exactly to have this result which we then see. We see the rotation of the spine. We have, of course, not morphological, but what we know according to Turner-Smith is that once we have our surfaces rotating, we know that the spine is also rotating. And if you take, let's say, 500,000 pixels on your surface, then you know if this area is moving during standing or rotating like this, then you definitely can repeat that and produce that. If you have questions during the session, we can either collect them or just ask whenever we have a microphone later on, so you're free to note them down and then ask. Right. So this is more in detail. We have here the strike with the strike projection on the back of the patient, and what you see here, other than other 3D scanners, is that you don't have to use markers. So the system accordingly is capturing C7, the vertebral prominence, and the dimples, and then is calculating the complete relief, which is the surface, so that we're able to reconstruct 100% surface just by gaining the complete convexity and concavity of the spine, of the back. Means the red area, it's not thermography, it's convexity and concavity. The red area is C7, for instance. The blue area is the spinal process, as we know, that is going along. And so, if the system is calibrated to a distance, you definitely will know that there is the spinal process. Now imagine this back would have any pathology besides scoliosis, you would be able to see that. So this was in 1985. And also here, of course, we have the studies we can provide. As I mentioned, yeah, dimples, this is the 4 points which we need to have a correlation. We have the C7, dimples left, right, and then the sucking point. Sometimes I'm faster than my slides, sorry. Yeah, in 96, this is where the university launched a spin-off, like let's say the formetric was founded, developed, where we started the commercialization of the system. Starting with a very, very niche market professions, orthopedic doctors in Germany treating scoliosis. That's a low percentage, of course, but this was used then in every orthopedic clinic, in every orthopedic practice. To assess it, and nowadays it's a standard not to do X-ray. So if the X-ray is, if the scoliosis is proceeding perfectly, we don't continue to do X-ray. If the X-ray, if the scoliosis is getting worse, you might do X-ray to see the morphology and to see whether surgery is needed. Then along, and this is just a bit of history, there was also the question: okay, how is the condition if I have a scoliosis? And my pelvis is like compensating, complete rotation. Let's say the patient is standing like this, and then you have pronation and supination. The main task for us was then to develop a simulation platform which is changing the foot position, and then also will change your spine. Also getting to know that you will change your pelvis. So might be that you change something in the foot, but then you don't change anything in the spine because the pelvis catches up everything. Okay? So it's compensating everything which you're changing here. All your ligaments are weak and so on. So aside from scoliosis, we do more and more to have more customers and users and universities doing studies on foot plantar position in spine. And the main task, still this was a problem, let's say a challenge, is to reproduce the analysis. So when you do an X-ray, today, tomorrow, or after 1 second, if you match them, they are completely different because it's a moment. Yeah, so you have a 3D image, a 2D image as an X-ray, and the main task here was to avoid this and to have a complete sequence. So DIERS then developed a 4D averaging, telling that we need more pictures during this measurement and then have an averaging so that the patient is easily standing habitually. So you could do then also neurological measurements, functional measures, everything which is related to sway is possible with this system. That's the 4D. Next approach was to do functional tests. Aside from Matthias' test, you also know maybe the Bromback test, which is a neurological test with open eyes and closed eyes. So the 4D opened up various applications. So Bromback test with open eyes and closed eyes, post-stroke patients, elderly patients to avoid falling, coordination tests, and further on. Thinking of the spine, also here, main task then was to save time. To say, okay, if I have the spine and I see and know exactly how the position is, I know where the vertebra is rotated, I know where the sips are, how the pelvic obliquity is, how the pelvic inclination is. If I have that, why don't we just add a platform under the feet and then measure the pressure and then see, okay, everything is related to the posture of my feet. So in this case, as an example, you would see this patient has a posterior weight distribution, and then you would be assuming, okay, this maybe causes coarctation or let's say a hyperkyphosis, yeah? And further on. So this was one of the first improvement where we started to add two systems in one system, in one concept. Furthermore, the next task, and this is 2 years later, because DIERS was developing also dynamic approach, because this is where physical therapy came into account, and physiotherapy, and said, okay, hey, listen, you have now the spine, we have the feet, but everything is in static. So static for some of us is boring, because it's like when you're standing in the traffic, you don't move. So it's better when you drive, so you have to move. So that's why we developed the 4D motion. Motion means everything is moving. So we created a faster camera, and then we were able to at least see the spine in movement. Very slow, it's like the Charlie Chaplin movies on a stepper, and then we started to develop it with a treadmill. And the missing part, of course, was then also to have that implemented with foot pressure measurement. Means that in this platform here, as you see, we have integrated sensors, and the sensors will also be with foot condition. Yeah? Plus, the missing link is the leg axis, where we have additional cameras. Furthermore, in the development, there will be, we added up EMG sensors, because especially during walking, the main question was, okay, what about the muscle activation? What about the muscle tonus? Especially when you're talking about post-surgical or like post-trauma patients, where you need to see the difference, balance, the activation of the muscles between right and left. Furthermore, we have a group of users, which is also maybe important for Thailand. They treat the maxillofacial joint dysfunction, meaning that not everything is coming from the feet when you change your pronation supination, but you also can do tests with our system where you have a tight occlusion, you have a tension, you have patients with neck pain, then you do an open mouth, you deliberate the jaw and then do another measurement, and then you can compare and see, okay, your problem is because of your jaw, not because of the feet. because everything which comes from here goes also down the spine. And you will see there is many approaches where to go. Then more closer to our days before pandemic, we developed a high performance lab, because here, away from physio and physical therapy, the demand was also there for sports people. Like having someone, like having a system that is unique, having the spine, the feet, the legs, everything in one system, which is not with fixed cameras in every corner of the room, but as you see, it's a fixed system that is calibrated in itself, where you have a complete assessment within. If you're fast and if you're good and experienced, in only 5 seconds you can do a measurement. We have clinics, they do 20 patients per day, not just 2 or 1, because they need to place markers everywhere. This is the great benefit, and if you check, let's say PubMed and everything which is related to DIERS and spinal surface topography, I believe you will be surprised how many publications there will be. I can provide you that. That's a huge list. For those who need a topic for their thesis, we can help you with citations of those books. Yes, the question was how many cameras this is. Let's say if you have a complete motion lab, you have one for the back, or formetric. Then you have one posterior leg axis. You have one lateral left, right, anterior. So 4 beneath and 1 for the back. 5. We will enter the software, so you will be able to see that. During pandemic, we were all in lockdown, but of course we had to work. We developed, starting in 2019, we developed an application where at the end of the complete measurement, from static, functional, and dynamic, the question is what to do with the data. What should I do with it? I have outpatients, inpatients, I don't know how to treat them. And people were staying at home, so we developed and linked our formetric with a QR code. So every patient that was measured got a QR code as a prescription for a training plan. So we recorded 680 videos, and then we have an algorithm which is taking the parameters and then creating this training plan, which you can use on your iPhone. Later on, you can scan a test trial QR code and see what I'm talking about. All right, this is what I've mentioned. So we have a 3D surface spine reconstruction, which is unique still because also here, this is clinically validated. We have a 4D averaging, means that we are able to do functional testings, especially in those fields which are not only static or everything which is related to scoliosis, but also for everything which is related to physiotherapy. Yeah? Here just some cases, hyperlordosis, osteoporosis. So it's not only about the youth, but also for, let's say, people in the golden age, where you have at least a hypertrichosis as an example, because walking like this is one of, let's say, most common back positions of the back. And maybe when you walk like this, and I think you will confirm this, is what you do when you walk like this, is you try to avoid falling. Yeah, this is falling the prevention. So in elderly people, it's necessary also to make balance tests, coordination tests with the patient just to stabilize the vestibular system and to avoid this falling, because falling in advanced ages is very elevated. So main thing is when you go forward, what happens? You cut your leg and then you start to walk like this. Yeah. So, and your task would be as a physician then maybe to straighten up the patient, but if it's too late because they didn't do sports, they didn't do exercises, then this would be your chance. But what the system is telling you, it tells you exactly if something has happened, if the change, or if the posture has changed. And why this is now an osteoporosis case, because the system is not invasive. Why are we showing that? We're showing that because, for instance, if these are 2 vertebrae, and you have osteoporosis, imagine. For those who don't know what osteoporosis is, it's like the bone density is reduced, especially in females with advanced age. So imagine you have a hyperkyphotic angle, and your kyphosis increases. The risk of a fracture, because the bone touches, the vertebra touches, is increased. So we do also have an index that shows you the risk of a vertebral fracture in a non-invasive system. So we have used that with osteology department in Hamburg, University of Hamburg. They took the system and measured osteoporosis cases and were able to create this index. Then we have a classical scoliosis. Let's say here this red curve is the spinal rotation, telling you, okay, the spine is rotated to the right. So the spinal process is going to the left. So the left curve is the spinal process curve, according to our algorithm. Then you have lateral projection, where you're able to see all the graphs which you as a physician would definitely see by your own eyes, but you wouldn't be needing to write them down. So the system takes 5 seconds to measure, so that you're able to have those measurements. Here are the functional tests, like Matthias. Dr. Matthias was one doctor. He said, okay, muscle imbalance might be the cause of postural deformities. So there is a test similar as wrong leg, but with open eyes, where you see, okay, children then might be collapsing because they don't have muscle, they have weakness in the muscle, so you're able to detect that. And also here, something happens with the pelvis, that's why you're able to detect also the SIPs, and then see what the pelvis is doing to compensate for it, because this is what we do usually. When you stand too long, you try to do this, yeah? All right. Here we have some clinical applications, which I have mentioned. So coming to the system which is then combined, as I mentioned before, you have the formetric here, you have your foot platform, and you can also select, of course, the simulations platform where you simulate pronation and supination. And this is one of the big advantages where you easily add up 2 systems, but also here save time and have a measurement of 5 seconds. All right. Especially when you have a patient and you don't know where the problem is coming from, as I mentioned. And here I just skip through the slides. It's about the temporomandibular joint dysfunction, as I mentioned before, where you have measurements with open mouth, like the patient is standing normal, is not doing anything, and then you do a posture assessment. But then you try also to measure with a strong occlusion and see how the tensions are changing. And then might be that the kyphosis will change, or something which is related to the rotation. But you can do it directly, yeah, with this patient. Or you treat the patient and say, okay, it's the ascending approach. I mean, everything is coming from the feet. So if you don't have it here, then it's coming from the feet. You have the simulation platform. You raise and lower the platform. You scan the patient. As you see here, we need to see 7 dimples without markers. We elevate 10 millimeters to the left. This is our spinal rotation. Or we test it and do 10 millimeters to the right. And at the end, you will be seeing, I don't know if you can see it, but it's unsharp. So the pelvic obliquity changes a lot more if you elevate to the right. So this could be one of the reasons. And then you do a foot scanning with the patient. After that, and let's say this is just in one day. Like you do this, it's 4 measurements on the same day, and then you check what changes. And these curvatures, they might be seeing very little in the difference, but we're talking about degrees that might be also painful already. So knowing that pelvic obliquity, if it's changed, it takes a while until the patient gets used to it. And if you have a pelvic obliquity, let's say a torsion of more than 3 degrees, he will start to feel the pain. That's why always here just in advance to see if the therapy which you're doing is helpful. Instead of like elevating the foot, you can also do manual treatment. Yeah, and then let the patient walk again, measure him again. There's also hip studies done with our system where you see the changes within after treatment directly. Right. So the consequence would be after, let's say, for instance, if you have, let's say, measurement and height adjustment, the consequence would be either to provide the patient with new orthotics, yeah, or do additional scanning with your podiatrist, or, and this is also one result of a cooperation with the university, to provide insoles that you give to your patient and then put into the shoe and then do also the measurement. And of course, posture changes after your treatment with the feet, so you have to renew the insoles maybe every 6 or 12 months. Yeah. So the approach is not only podiatry or orthopedic clinics, not even just scoliosis clinic, but all in the range of development. It has increased not only for shoe assessment, but also giving the chance to have an assessment in early detection of postural deformities, and then maybe decide whether the surgery is necessary, or you go into surgery and then you have your physiotherapists and your rehabilitation process after. Just for instance, if you take post-stroke patients as an example, after they start to walk again with their exoskeleton or whatever, you can also undergo it with the DIERS formetric on the treadmill, so you're able to see whether the sway in the posture is getting better or worse. All right. Then shortly, just in a dynamic position, what we have here, everything which we know from static is dynamic, so here we have to place markers and we let the patient walk onto a treadmill. So we have C7 and dimples. This is what we know exactly, and this is what we want to see. The system automatically calculates or gives you the information where the highest rotation is. Is it in T3 or lumbar spine 2, 4? It gives you the pelvic rotation down here, and it gives you the complete rotation and of course the sway. Furthermore, and this we will see in the hands-on, it will give you complete pelvic drop during walking, and this then is your task to go down or up and then see where the change is. And this is just a representation of 5 seconds. Yeah? Here we have the pelvic drop. And also here we increase the pelvis. So once you have something with the pelvis, and this is the missing part, was to gain a complete assessment then, and to complete the gap between spine and feet. Where we added up leg access cameras, those cameras which are on the side. Yeah? Getting you the information of varus and valgus during walking. With a speed of 5 kilometers per hour maximum. But if you're talking about sports, then definitely you would need to have a bigger treadmill because you have a bigger path. Talking about a speed of 30 kilometers per hour if you do a sprint as an example. So imagine you have an ACL customer or ACL patient, and you would be doing the follow-up measurement. You'd be able to see lateral and posterior leg axis and see, okay, where is his shifting, right, his compensation. Then the treadmill, the pedal-gate, which is aligned with the sensors, this was the main task to integrate not just only a platform with sensors that gives you the pressure, but also use normative data. Normative data also because everyone has learned this or still in the progress to dive into those phases during walking. So we integrated this in our system and our software, giving you the complete step length during walking on the treadmill to give you time, the cadence, all the pre-swing phases that you need. So and within 5 seconds, of course you can measure longer, you will get those data in our software.
So for this one, for the other one, in static, you don't need to baseline. In dynamic, you need to baseline because it's a video.